Welcome to the presentation for Nursing 150 Module 9. This presentation will focus on hypertension, the causes, risk factors, pathophysiology, treatment, and nursing care of a patient with hypertension. It's important to review the pathophysiology of arteriosclerosis and atherosclerosis when talking about risk factors related to a patient developing hypertension. Arteriosclerosis is referring to the thickening or hardening of the arterial wall that is often associated with aging. Atherosclerosis is more about it's a type of arteriosclerosis, but it involves the formation of plaque within the arterial wall. It is the leading risk factor for cardiovascular diseases. Patients who have developed arteriosclerosis or atherosclerosis are at risk for developing hypertension. Hypertension being increased pressure within the vessels of the cardiovascular system. Mechanisms that influence blood pressure are the cardiac output, so that means the arterial blood pressure that is needed to produce adequate cardiac output from the left ventricle. And then the total peripheral vascular resistance. So that's the resistance of the vessels that the left ventricle is pushing against when it puts its cardiac output. So any disease process that can increase peripheral vascular resistance can affect your blood pressure. This is a picture just to have a visual of the atherosclerosis as it occurs and as it gets worse within the wall of the artery. This is what the blood flow of a normal artery should look like. It should be open and blood freely flowing. This is when there's a buildup of plaque within the arteries. And then, of course, this is where there's a large buildup of fat and plaque within the arteries, causing poor blood flow through it. This leads to increased peripheral vascular resistance. So if you think about the heart pumping here, blood out of the aorta, and then the left ventricle has to pump blood out to the rest of the body. If the rest of these arterial walls are all blocked, the heart has to work extra hard in order to pump that blood against that peripheral vascular resistance. And that causes increased blood pressure. And this is basically just a summary of what I just said regarding the association of atherosclerosis and arteriosclerosis to hypertension. Anything that affects your cardiac output, your peripheral vascular resistance, such as arteriosclerosis or atherosclerosis. These are factors that increase the peripheral vascular resistance, the heart rate, stroke volume. This all increases your blood pressure. Other things can affect your blood pressure, such as change in fluid volume. Anything that it causes an increased fluid volume. So if a patient is holding on to fluid instead of excreting it through the kidneys, that would increase your peripheral vascular resistance. So that would increase your blood pressure. If you have a decreased volume in your cardiovascular system, maybe patient is bleeding a lot, which would decrease the volume of circulating blood through the cardiovascular system. This perhaps would drop their blood pressure because it decreases your peripheral vascular resistance. It's also important to go back and visit that renin-angiotensin-aldosterone system that regulates your blood pressure. Remember, your kidney produces renin, which is an enzyme that acts on angiotensin, which splits off into angiotensin 1, which is converted by an enzyme in the lung to form angiotensin 2. Angiotensin 2 has strong vasoconstriction action on the blood vessels and is a controlling mechanism for aldosterone release. Remember, we talked about aldosterone as a hormone that is released from the adrenals that are near the kidneys, and they work to help to balance fluid and electrolyte numbers, and by doing this, it regulates blood pressure. So really, just in summary, it's important to understand that the kidneys and some of those hormones and enzymes that are released by the kidneys play a role in the part of regulating the blood pressure. Remember, we always try to follow the best evidence-based practice when we consider treatment and diagnosis of any disease process. For blood pressure, the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure meets, I think, about every 4 years, and they come up with the best evidence-based guidelines for the management of high blood pressure in adults. In 2014, they met and they came up with the JNC, which stands for the Joint National Committee, for their 8th time, and they came out in 2014 with their latest and greatest in their guidelines for treatment, diagnosis, detection, and evaluation of high blood pressure in adults. These are the most recent guidelines. This has probably been the biggest change. They've kind of reconsidered, and it used to be, we used to have this number, 120/80, 120/80. Now they look more at the patient's age. If the patient is over 60, they are more lenient as far as what their blood pressure should be. So the older the patient gets, the numbers change a little bit. People younger than 60, we are considering high blood pressure as 140/90. You're probably used to that number. And a patient over 60, high blood pressure is considered to be 150/90. So essentially what they said, the ideal blood pressure for a patient 60 years and older should be less than 150/90. For a patient who's 60 and under, the ideal blood pressure should be less than 140/90. Hypertension is further classified into primary and secondary causes. Primary hypertension, also known as essential hypertension, is the most common type. It is not caused by an existing health problem. This type of hypertension is usually caused because of risk factors such as diabetes, obesity, nutrition, cigarette smoking, high stressful life, things like that. Secondary hypertension is associated with disease states and drugs, such as other medications that will increase a person's susceptibility to hypertension. A person with these types of elevation in blood pressure is known as secondary hypertension. Kidney disease is one of the most common causes of secondary hypertension. And this is usually due to damage as far as the filtering mechanisms of the kidney, and then, of course, that renin-aldosterone system, maybe in some dysfunction in the adrenal. Mediated hypertension can be caused due to aldosteronism. Remember, high blood pressure can result in excessive cortisol levels and excessive aldosterone levels in Cushing's disease. So that would be a secondary cause of high blood pressure. Treatment for Addison's disease, such as glucocorticoids, mineral corticoids, can put a patient into Cushing's disease if they take too much of it. So that could be medications that can cause a secondary cause of high blood pressure. Some estrogens, some oral contraceptives that have estrogen in them can cause hypertension in some women, and usually that's women over the age of 40 that smoke. That can cause high blood pressure in them. A higher percentage of men than women have hypertension until age 45. From 45 to 54 years old, women have a slightly higher percentage of hypertension than men, which is an interesting factor. One other thing to understand is the prevalence of hypertension in African Americans in the United States is among the highest in the world. So culturally, African Americans tend to get high blood pressure, and that's usually a primary cause of high blood pressure. Prolonged untreated high blood pressure over time can begin to damage vessels and organs in the patient due to the constant increased pressure within those vessels. Can begin to cause heart failure. If the heart has to work hard every single day in order to fight against that increased peripheral vascular resistance, it can begin to damage the heart. The kidneys, under high pressure for a long period of time, it can begin to damage the filtration mechanisms, the nephrons within the kidneys. The vessels of the eye, prolonged high blood pressure in those vessels can lead to poor eyesight, vision changes. And then, of course, high blood pressure within the vessels within the brain can lead to a stroke. Athersclerosis in the vessels of the brain can also clot off or can clog an artery so that there's not good blood flow to the brain tissue. It can also cause a diseased area, a weak area in the arteries within the brain that can put the patient at risk for having a bleed. If that vessel wall bursts open, the vessel wall can be weakened by the increased pressure from the high blood pressure over a long period of time, and it can cause a bleed within the brain, which can be very detrimental. That is also known as a hemorrhagic stroke in a patient. So it's important that we know that we educate patients about the complications associated with high blood pressure. The interesting thing is that a lot of people can walk around with high blood pressure and not have any signs or symptoms. You don't know it. Maybe they just walk into their doctor's office for another reason. And, you know, they're always checking our blood pressure. No matter what reason we come in, they still check our blood pressure. So, and they're doing that because people can have high blood pressure without even knowing it. That's why they always screen us when we go in. So patients need to be educated that they won't necessarily feel bad. It's kind of like a silent killer. It's kind of been nicknamed because, like I said, they can walk around and have all this occurring in their body and really not be very symptomatic. It's also difficult to get people to want to take treatment and seek treatment for it. If they don't feel bad, if it's kind of like if it's not broke, I'm not going to fix it type of thing. Because, like I said, they really don't feel that bad. And the important thing to know is they really don't feel that bad until it's too late. So it's a big education piece for patients with hypertension. Over time, severe high blood pressure can begin to cause the patient to have some symptoms. And a lot of times people don't understand that it is associated to their hypertension. Maybe they're having headaches. Maybe they're having dizziness, but they might just think it's something they ate, or maybe they think it's sinuses or something like that, because it's really kind of vague symptoms that a patient may present with. And that's why, like I said, your doctor will always check your blood pressure when you come in just to see if it has anything to do with it. Patient history, of course, when we're assessing a patient, maybe they come in with a blood pressure of 158/92. We'll kind of look further at them. You know, what kind of medications are you on? What kind of lifestyle do you live? What other medications are you on? Do you have a family history of high blood pressure? Do you have high cholesterol? Do you have diabetes? Things like that. Physical assessment. Of course, your blood pressure is going to be part of that, assessing the blood pressure and assessing the heart rate. One thing to look at is orthostatic hypotension. If someone is coming in with fainting or dizziness, it could be a symptom of orthostatic hypotension, which means that when a patient goes from a sitting to a standing position, they drop their pressure. This is usually due to just that quick change in position can cause you have these baroreceptors that kind of regulate your blood pressure according to, you know, your posture and everything, or your position. So if you get up too quickly, sometimes it can drop your blood pressure because it doesn't give those baroreceptors in your body time to adjust the blood pressure to it. So like I said, that, and so make sure you understand how to check an orthostatic hypotension. Of course, you would check their blood pressure as they're sitting, give them a few minutes, and then have them stand up slowly and then re-record their blood pressure. Sometimes if people do have a bit of orthostatic hypotension, it's good to educate them to stand up slowly. When they get from a sitting low position, as they get up, they can just kind of get up slowly, and that can prevent that. It gives your body more time to adjust to the change in position. Other things to assess for is any kind of stressful situation in a patient's life that can make their blood pressure go up, job related, maybe it's money, maybe it's just going to nursing school, things like that. Diagnostic assessment, there's really no laboratory test that can give us a definitive diagnosis of hypertension, especially primary hypertension. Secondary hypertension, we have a little bit more things to choose from in order to diagnose that. That would be like if we check their BUN and creatinine and found that they do have some kidney problem, they have a bad kidneys, like if their creatinine and BUN are elevated, telling us that their kidneys are not working properly. Urine tests could tell us that maybe there's catecholamines in there, if it's due to a Cushing's or a treatment for Addison's. We'll do urine tests for that. And then, of course, we'll do a renal panel, like an electrolytes. We'll look at their serum and electrolytes, look at their hydration status, things like that. I already kind of referred to these as far as doing the BUN, the creatinine, urinary test for cortisol, catecholamines, and things like that in order to check for causes of secondary hypertension. A lot of times when a patient does present with hypertension, and maybe they don't meet the picture, maybe they are very in shape, they're very active, their cholesterol's low, they don't have a family history, they don't smoke, then definitely they would want to rule out secondary causes for their hypertension because they don't fit the picture of somebody who might have a primary hypertension. For all of those people that do fit the picture for primary, this is kind of the labs that we would do maybe to kind of look at to determine if the patient has a primary hypertension. Their cholesterol levels are high. And remember the difference between HDL and LDL. HDL is the good cholesterol. That's the high density lipoprotein cholesterol that takes the cholesterol that we manufacture and helps deposit it out of the body. The LDL cholesterol is the kind of cholesterol that takes the cholesterol to the arteries and causes a plaque to build up. So remember that we want the LDL cholesterol less than 130 and the HDL cholesterol greater than 40 in most individuals, unless these patients have been identified as people who have higher risk factors, such as a first-degree relative, family history, things like that. Other things, and then, of course, we would assess these labs. If they are elevated, we would implement teaching and interventions to hopefully decrease their cholesterol levels. Usually they'll start out with lifestyle changes first, changing your diet to foods more less in fat, higher in protein, less carbohydrates, high fiber, and more vegetables, more fruits and vegetables, less red meat, things like that. Drug therapy, it would be for your high cholesterol is going to be mostly your statin medications, your simvastatin, your atorvastatin. We'll talk about those a little bit more in class. Usually the education that goes along with taking those statins is to report immediately any sudden muscular aches and pains, especially if they're severe. The other thing is you need to monitor a patient's hepatic panel frequently while they're on a statin. The other thing about statins is it works more effectively if a patient is treated at night, so they usually take their statin medication at night. It is thought to work better that way because a patient, it's thought that we produce more cholesterol during the night, and so it works more effectively if we take it during the night. It can also cause some nausea and some stomach upset, so they feel like it works better if somebody takes it at night. It doesn't bother them as bad. There is a drug alert in your book about statins reduce cholesterol synthesis in the liver and increase clearance of LDL from the blood. Remember, we want to get rid of the LDL because it's the bad cholesterol. And therefore, it is contraindicated in patients who have active liver disease. It's also contraindicated during pregnancy. There do have some potential interactions with warfarin, which is a anticoagulant, so we have to be careful with that. Teach patients taking statin drugs, especially those taking atorvastatin, lovastatin, and simvastatin, to avoid grapefruit and grapefruit in their diet. Grapefruit contains chemicals that bind to and inactivate the effectiveness of the medication. They also could have some GI upset, bleeding, so it's just a good idea. They are effective medications, and these side effects are somewhat rare, but they are important for us to look out for. Exercise and smoking cessation can literally, if someone can increase their exercise and stop smoking, they can honestly probably cure themselves from having high blood pressure if that's a primary high blood pressure being caused by this. So education is really, really an important thing. I mean, we might not even have to put them on any low blood pressure lowering medications if they're able to do this effectively. Complementary and alternative therapies all consist of ways of helping a patient decrease the stress in their life and being able to calmly, slow down and decrease stress and just maybe kind of stop and smell the roses a little bit. There's lots of hypnosis. There's lots of kind of ways of doing, calming, meditating, things like that. There's also thought to be garlic is a way that can lower blood pressure, garlic supplements. That would, of course, have to be checked with the doctor to make sure that it's not get contraindicated, that they take maybe some garlic tablets and things like that. So there are thought to be lots of ways that we can kind of help non-pharmacologically treat a patient with primary hypertension. If those aren't effective, we will have to move on to giving a patient medications to lower their blood pressure. And we'll talk about that in the next few slides. This is, again, just ways to prevent high blood pressure, lifestyle changes, increase exercise, decrease stress in their life, change their nutrition, drug therapy, maybe some cholesterol-lowering medication possibly could help them decrease the plaque buildup and hopefully decrease blood pressure in some patients. The next slide we'll talk more about drug therapy associated with blood pressure. Drug therapy for high blood pressure, and this is for a patient possibly with primary hypertension that we've done non-pharmacological treatments such as change in exercise, change in lifestyle, decreasing their cholesterol, changing their diet, and that has not been effective. They still have high blood pressure. So we will put them on medications, and it's usually individualized. Usually we start out with a thiazide diuretic. Again, we go back to the guidelines presented by the JNC8 in 2014. They recommend the use of one or more of the 4 classes of drugs. And here's our goal. Really, our goal is to just do the simplest regimen. And so if we can just give one pill that they can take once a day, patients are known to be, it's known to be more cost effective. It's known to be more, the patients are more compliant with the treatment. There's a great table in your IGGI book about the evidence-based recommendations for the management of high blood pressure in adults, according to the JNC8 guidelines. And so that kind of just guides treatment for the provider in order which drugs to choose first for your patient. Like I said, thiazide diuretics have been shown to be the most effective and the most cost-effective treatment. So this is usually what we choose first. Calcium channel blockers is our second go-to. Angiotensin converting enzyme inhibitors, or ACE inhibitors, are among those 4 that JNC8 says to use. The 4th one being ARBs, which is angiotensin receptor blockers. Patients who do not respond to the first-line drugs may be placed on aldosterone receptor antagonist, beta-adrenergic blockers, those are beta blockers, or renin inhibitors. So Basically, that's kind of the order that they would like for us to treat because those have been found evidence-based to be most effective. Diuretics are the first type of drugs for managing hypertension. Basically, they decrease blood volume, and by decreasing blood volume, they lower blood pressure. Thiazide diuretics are essentially pretty cost-effective. They are usually the drugs of choice for patients with uncomplicated hypertension. They can be used as single agents for treatment of hypertension or in combination with other drugs. It's important to teach men. Men may experience a decreased libido due to taking thiazide diuretics, so that could decrease their compliance. So we have to make sure we kind of monitor for complaints of that. Thiazide diuretics should be used in caution with patients with diabetes, mellitus, because they can actually interfere with glucose control. So we might have to use that very cautiously in a diabetic patient. It also can cause patients with gout to have worsened their symptoms of gout. So there are some contraindications, but usually a pretty effective medication. Loop diuretics can also be utilized. Loop diuretics being furosemide, torsemide. They can be used pretty effectively, and they're pretty cheap and pretty easy. However, they do make a patient pee more, which can be kind of annoying to a patient. So, and it also can lower their potassium levels, so you have to be very careful about monitoring their potassium and potentially giving them a potassium supplement if you treat them with loop diuretics. Also, if it's used in older adults, it has to be used very cautiously because we know that older adults, we're talking like 70, 80 years old, they are prone to getting dehydrated easily. So if we're using a medication that makes them even more dehydrated, that could cause a lot of orthostatic hypotension and possibly a safety issue in older adults. Calcium channel blockers such as amlodipine, that seems to be the most common one these days. Basically, they result in vasodilation, which decreases your blood pressure. So by vasodilating, it decreases peripheral vascular resistance, which causes a lowering of the blood pressure. Calcium channel blockers are pretty safe to use as well. They seem to be pretty effective in African Americans in the treatment of primary hypertension. On all of these medications, we're giving these to patients to get them to lower their blood pressure. So it's important to teach your patient taking these meds to monitor their blood pressure and their heart rate. Calcium channel blockers can lower your heart rate as well, so it's important that the patient make sure they monitor it, make sure that they're not getting too much. ACE inhibitors are usually the third line that we might utilize in a treatment of a patient with high blood pressure. These are known as lisinopril and enalapril. They end in the prils. So basically, they block that action of the angiotensin converting enzyme there down by the kidneys that causes vasoconstriction. If we can prevent vasoconstriction, that means that we can keep the vessels dilated, so that in turn lowers blood pressure. The problem with ACE inhibitors, in some patients, they can cause an extremely nagging dry cough, and it's sometimes just this chronic cough that they get with taking it. If that's the case in a patient, we will go ahead and change them to an angiotensin II receptor antagonist known as an ARB. Valsartan and losartan is an ARB. Those are works again near that angiotensin II receptor site, allowing the blood vessels to remain vasodilated. One thing you need to teach your patient about the ARBs is they need to avoid foods high in potassium, and that's due to the fluid and electrolyte balance that occurs with the angiotensin-aldosterone receptor areas there. ARB can cause a hyperkalemia, especially when combined with other antihypertensive drugs, so you just have to watch their potassium levels. And again, with all these meds, they have to be able to monitor their blood pressure and their heart rate. Beta blockers are also a drug commonly used. They're more commonly used in patients who have had cardiac problems such as a myocardial infarction. It's a cardioselective drug. It blocks the beta receptors in the heart. So the beta receptors respond to epinephrine and norepinephrine, which are catecholamines that increase your heart rate and increase vasoconstriction. By blocking this mechanism, we can keep the heart rate lower and the blood pressure lower. Basically, it just keeps the body chill. It keeps the heart chill. It keeps it from responding to stressful events that cause a release of epinephrine and norepinephrine, which causes that kind of norepinephrine and epinephrine cause that fight or flight response that where your body gets all tense and your heart rate goes up and your blood pressure goes up. So beta blockers block that response. So it keeps your heart from working too hard. And that's why it's a good drug to give for patients who have some heart disease secondary to a cardiac event. These drugs can all cause an orthostatic hypotension, especially in older patients. It's important to tell them to rise slowly, especially when they first start taking these medications. Some examples of beta blockers is metoprolol. You've probably given that a lot. Atenolol is another one. They end in LOL. These medications can cause a patient to feel pretty tired. So a lot of times patients are non-compliant, and that's why it's kind of further down on the list here. A lot of patients are non-compliant with their beta blockers because it makes them feel kind of crappy. It makes them have sexual dysfunction, fatigue, depression. So that's why it's an effective drug for blood pressure, but sometimes it has side effects and the patients will not be compliant due to those side effects. This is just a little bit further explanation regarding the calcium channel blockers. Again, like I said, these are the most effective in older adults and African Americans, causes vasodilation. This works to cause vasodilation by interfering with that calcium ion exchange that occurs with stimulation and conductivity of the cardiac cells. This is just, again, kind of review of what I said on the last slide about the blood pressure medications, ACE inhibitors. Remember, there's a cough. That's a side effect of ACE inhibitors. All of these ACE inhibitors end in pril. It's lisinopril and enalapril. The ARBs are the sartan, valsartan. So if you notice, a lot of these meds have a lot of their endings are similar, so it's kind of helps us a little bit to classify them. And remember, usually people are moved to an ARB when they can't take the pril or the ACE because of the cough. Just another review of beta blockers. When we're talking beta blockers, those medications end in, wait a minute, let me go back. That's not correct. Or just let me scribble out. Those are LOLs. Metoprolol, atenolol. Those are the beta blockers, and it works by blocking that beta-1 receptor in the heart, which, again, it is a good drug of choice for patients who have an ischemic heart disease secondary to maybe a cardiac event, because those patients, we want those hearts to not have to work hard. We want to decrease the workload of the heart, so that's why beta blockers are the drug of choice for those patients in combination with ACE inhibitors. We like those two drugs for treatment of hypertension in a cardiac ischemic heart disease patient. The following slides are review questions to just assess your learning from the presentation. I encourage you to attempt to answer the questions on your own and check your answers within the PowerPoint posted and the additional resources. I look forward to discussing these topics in class with you.